Hey guys, welcome everyone to PW Method. So we are continuing our Reed Harrison series, and in this module we will be addressing the stroke. Now, stroke is a mega topic, and we will be dividing it into multiple sessions so that we understand the key points precisely and firmly. We will begin with the basics first because I understand that many of you are just into your second year of MBBS or maybe just into third year of MBBS, and you might not have got sufficient basic exposure. So we will begin with the basics. We'll first try to understand what is stroke. Okay. Is there anyone who is making an attempt to give me an answer? What is the meaning of stroke? Can I say that anyone who presented with hemiplegia is having stroke? If I make the statement, am I correct or false? Like all the patients with hemiplegia have stroke. True or false? Gaurav, Nilanjana, and Parneet, good evening, everyone. Okay, so Gaurav says decreased blood supply to brain is equal to stroke. Okay. So what I will do is I will put across three scenarios and you should tell me which one is stroke. Okay, good evening everyone. Good evening everyone. So here is the first one. A patient had sudden onset right hemiplegia that lasted for 1 hour and resolved. He had right hemiplegia that lasted for 1 hour and resolved. Can I count it as a case of stroke? He had hemiplegia, right? Some part of the brain, to be precisely, it has to be either brainstem, subcortex, or cortex, which was dysfunctional, and that is why he had hemiplegia, and it has improved within 1 hour. So can I call it as stroke? Nilanjana, you are pretty close. ABC user, right? So the first scenario, I think most of you would probably agree that we can end up calling it as transient ischemic attack or TIA. Check the record, absolutely right. So if I have a tumor, let me say in the tumor affecting the motor cortex, or a tumor of the brainstem, or tumor of the subcortical region, I may even get the hemiplegia there. So hemiplegia merely tells me that which part of the brain is dysfunctional, right? But not all causes of brain dysfunction are because of stroke. Okay, so first scenario, I think most of you got it right. We could probably call it as TIA. Okay. Now the scenario number two. Patient with hemiplegia that is persisting since 2 days and a CT scan of the brain shows that there is intracranial bleed. So can I call it as stroke or not? Can we call it as stroke? Patient has hemiplegia. It is there from 2 days and we have got a CT done. It shows that there is a bleed inside the brain. So can we call it a stroke or not? Satya, I am is absolutely right. So this can be counted as hemorrhagic stroke. So the first scenario you called it as transient ischemic attack. The second you called it as hemorrhagic stroke. Okay, now I will give you a third scenario. A patient had sudden onset right hemiplegia and died after 3 hours. Okay. And if I tell you that we got an MRI done before he passed away, and an MRI showed that there was an infarct. There was an infarct in MCA territory. Can I say that this patient died because of stroke? Can I say that this patient has stroke? He died within like 3 hours after the onset of hemiplegia. Right. This can be counted as ischemic stroke. So now you should help me summarize what is the definition of stroke. You have got the concepts right. So you know what is TIA. You know what is hemorrhagic stroke. You know what is ischemic stroke. So now tell me what is stroke in simple terms. So Nilanjana had given a very concise and a simple definition. So basically, stroke is nothing but focal neurological deficits. It can be global but rare. Focal, rarely global neurodeficits. Focal neurodeficits due to vascular insult. Vascular insult. Now, what is the meaning of this definition? When I say focal, means some part of the brain is becoming dysfunctional. When you say global, whole of the brain is becoming dysfunctional. Most cases of stroke, it is generally some part of the brain that is becoming dysfunctional, leading to loss of functions of that area of the brain. And this is happening because of a pathology affecting the blood vessels, right? That's why I'm using the term vascular insult. Now, what can affect the blood vessel? Two things can go wrong with the blood vessel. First thing, the blood vessel can get blocked either because of atherosclerosis or emboli. Or second thing, blood vessel can open up and bleed. So when it leads to occlusion of the blood vessel, and because of that, blood supply to the brain tissue is cut, we call it as ischemic stroke. Ischemic stroke. And when it is due to bleeding into the brain parenchyma or brain tissue, we call it as hemorrhagic stroke. Hemorrhagic stroke. But this definition is not complete. So when you look at most of the books, the definition goes like this. This neurodeficit should be persisting for at least more than 24 hours. So if the deficits improve within 24 hours, what do we call it as? So like a patient has developed hemiplegia or any other focal neurological deficits, monoplegia or any other focal neurological deficits, which is because of either a blocked blood vessel or bleeding from a blood vessel, and the symptoms are lasting for more than 24 hours, it is a clear-cut case of stroke. But if the symptoms improve within 24 hours, what do we call it as? If they improve within 24 hours, as you know, we call it as TIA. So TIA basically refers to focal or global neurological deficits which improve or which last for less than 24 hours, which last for less than 24 hours. Simple definition, right? Now let me take you through a challenging scenario. So here is a question. Let us see if we can answer this. We have a 45-year-old smoker who presented with right hemiparesis and Broca's aphasia. The symptoms persisted for 40 minutes and resolved spontaneously. A CT scan was performed on arrival which showed no bleed, while another MRI scan was performed which showed a small infarct in the left MCA territory. What is the likely diagnosis? What do you think should be the diagnosis here? A relatively young, probably suffering because he has smoked quite heavily, a smoker presented with right hemiplegia and Broca's aphasia. And his symptoms, the hemiplegia and aphasia, lasted for only 40 minutes and after that improved. So when he came to the emergency room, he was probably on the way to improvement. We got a CT done which showed no bleed, so that means it is not hemorrhagic event. We got an MRI which showed a small infarct in the left MCA territory. What is the likely diagnosis? Okay, so how many of you think it is option A, acute ischemic stroke? And how many of you think it is TIA? So this is the most confusing question that most of the apps, exams begin with. First, clearly understanding what is stroke and what is transient ischemic attack, right? I will come back to this question after presenting the definitions of stroke. So here what you see on the screen is the WHO definition of stroke, which says rapidly developed clinical signs of focal or global disturbance of cerebral function lasting more than 24 hours or till death. Because what happens, sometimes stroke can be so massive that patient will die within few hours. We can't say that, okay, because patient has died and his hemiplegia is not lasting for more than 24 hours, he is not a case of stroke. So lasting for 24 hours or till patient's death with no apparent cause other than vascular origin, then we will call it as stroke. So vascular origin, and on the basis of that, we will classify it into, as I just told you, hemorrhagic and ischemic stroke. So we will have two categories. If bleed happens, we will call it as hemorrhagic stroke. And if an occlusion happens and an ischemia to the tissue happens, we will call it as ischemic stroke. Okay. TIA is a concept that applies to patients who are at risk of developing a full-fledged ischemic stroke. Okay, now what is the definition of TIA? Transient ischemic attack. A transient means short lasting episode of neurological dysfunction caused by focal brain, spinal cord or retinal ischemia without an acute infarction. And here the term transient basically refers to symptoms lasting for less than 24 hours. Lasting for less than 24 hours. I want your attention on a point here, that is without acute infarction. So if you present to me with some focal neurological deficit, let me say that you have got a right hemiplegia or a left hemiplegia or Wernicke's aphasia or Broca's aphasia, and the symptoms have quickly improved within 24 hours, they have completely resolved to normalcy. But if I find an infarction on the CT scan, it will be still counted as a case of stroke and not TIA. TIA means we have to have two things. Symptoms lasted less than 24 hours and we find no evidence of stroke on imaging, no evidence of ischemia on imaging. Only then we will call it as a case of TIA. So now look at this question and tell me, should we call it as TIA or should we call it as an ischemic stroke? So these patients' symptoms have definitely improved in a very short span of time, right? So it fits into that definition of TIA. But when we did an MRI, we could clearly find that there was an infarction in the left MCA territory. So that clearly means that this is a case of acute ischemic stroke. So we will stick to the diagnosis of ischemic stroke. So now I hope we have the clarity. What is stroke? When some part of your brain loses function because of a blood vessel dysfunction, which could be either block or bleed. Then we call it a stroke. But to call it a stroke, symptoms should persist for more than 24 hours. If they resolve within 24 hours, we can call it as TIA, provided on the imaging there is no infarction. If infarction is present, so that is the point. If it is within 24 hours, even if the symptoms have improved, if you find an infarct, it will still be considered as a case of stroke. We will understand a little bit about it when you look at the pathophysiology. So basically what happens is, let me give you an idea about the pathophysiology. So basically what happens is, let me say that this is one area of the brain that we are looking at, and this is one blood vessel which is supplying the blood supply to it, right? This is a brain area. Just imagine some area of the brain, and this is a blood vessel that is giving blood supply to it. When I cause an obstruction to it, let me say that there is narrowing of the lumen by 70%, 80%, blood flow to this area is cut off, right? Now what happens? The core area of this core, or the center of this area supplied by this blood vessel, is the first one to start suffering the consequences of ischemia. Means this is not getting the sufficient blood supply. The peripheral area is getting reasonably perfused. So now what will happen? This core will start dying. So it will become an infarcted zone. When it dies, we call it as infarction. This is infarcted. Now will this area be working? No, this loses its function. Okay. Now what about the surrounding area? The surrounding area has got reduced blood supply, but not too low to die. It is not infarcted yet, but its blood supply is reduced. So this also is not going to work because it is not getting sufficient blood supply. This area is what we call as ischemic penumbra. Ischemic penumbra. So the core has died, infarcted, it is not working, and the surrounding area we call it as ischemic penumbra. This tissue is viable, it is not dead yet. If you re-establish the blood flow, if I dissolve the block and re-establish the blood flow, I can recover this area. I can recover this area. So now what happens if I have a block and if an infarction has happened, which is visible on the CT scan, we will count it as stroke. If the functions have improved, is come back to normalcy, it is because the surrounding area has recovered and it is taken over the function done by this dead tissue. That is why he has recovered. But he has an infarction. As long as he has an infarction, we will call it as stroke and not TIA. That is the first take home message. Okay. So now we have understood what is stroke and what is TIA. The next step we need to understand is how we classify stroke. Okay. Broadly speaking, stroke is classified into two groups, that is ischemic stroke and hemorrhagic stroke. But ischemic stroke has further classification. So let us divide the cases of stroke into ischemic and hemorrhagic. My first question is, which one is more common? Which types of stroke you have seen in your clinical practice more commonly, like in your hospitals? Which is more common, ischemic or hemorrhagic? Right, it is the ischemic which is more common. Generally speaking, ischemic strokes account for around 85% of cases and hemorrhagic strokes account for around 15% of cases. Okay. Now, can anybody tell me about subtypes of hemorrhagic stroke? When bleeding happens and it is because of a vascular insult, we have two subtypes of hemorrhagic stroke. The first one is intracranial bleed. Intracranial, to be more precise, I will call it as intraparenchymal bleed. Means it is the bleeding into the main tissue of the brain. Intraparenchymal bleed. Usually we call it as intracranial hematoma or ICH. And the second one is subarachnoid hemorrhage, bleeding under the arachnoid space. Subarachnoid hemorrhage. Okay. Now, why am I not listing the epidural hemorrhage and subdural hemorrhage under hemorrhagic stroke? Akshay Pal Singh, good evening. So, the we are going there, we will understand why hemorrhagic stroke also happens. Why we are not considering subdural bleed? See, you know that you have the dura mater, arachnoid mater, and pyomater, right? The subdural bleed is not considered, or epidural bleed. See, this is dura mater, right? Arachnoid matter, pyomater. Subarachnoid bleed, bleeding beneath the arachnoid membrane. We call it as stroke. But bleeding happening beneath the dura, subdural bleed, and epidural bleed, right? Outside the dura. We are not calling it as stroke. Why? So please remember, most cases of epidural and subdural hemorrhages are because of trauma. They are not because of a blood vessel dysfunction. When road traffic accidents happen or something like that, we will call it as the epidural or the subdural bleeds. But subarachnoid hemorrhages are often because of either vascular malformations or because of hypertension. Even trauma can cause, but otherwise they can be because of vascular pathology, and that is why it comes under stroke. The definition of stroke says focal or global neurological deficits due to vascular insult. Clear? Okay. Now they will ask you one question. What is the most common site of intracranial bleed? अक्षय पल कोशिश करता हूं. What is the most common site of intracranial bleed? कहाँ पे होता है? And what is the most common cause? The most common cause for intracranial bleed is hypertension, and the most common site is the most common site. This is an MCQ. The most common site is basal ganglia. Basal ganglia. And you know that basal ganglia have so many nuclei. तो कभी कभार ये भी पूछते हैं कि precisely कौन सा nuclei? Precisely which nuclei? Yes, the most common cause is hypertension, and the most common nuclei which gets affected by intracranial bleed is putamen. Putamen is the most common site for intracranial bleed in a hypertensive patient. Okay. Now let us shift our focus to the ischemic stroke, because that is the most common, accounting for 85% of the cases of stroke. The ischemic stroke is further classified. This classification system is called as TOAST classification. Now, if you are asking me, sir, what is the full form of TOAST? You don't need to remember. Basically, it is classification system that authors of a particular study of a drug called danaperonide, it's an heparin derivative, which was tried in patients with stroke. So this TOAST classification comes from the trial, which stands for trial of org, the org, some number. The number is the drug trial number for acute stroke treatment. So TOAST classification. So ischemic stroke is further classified into 5 categories. One category is large artery atherosclerosis. When we say large artery, basically it refers to internal carotid artery, middle cerebral artery, or anterior cerebral artery. Atherosclerosis of these large blood vessels. Okay. And this is the most common subtype of ischemic stroke, where there is an atherosclerotic plaque causing the occlusion, eventually rupture, thrombus formation, and development of a stroke, either in the internal carotid artery, middle cerebral artery, or anterior cerebral artery. Then we have the small arterial occlusion. There are some small branches of MCA and ACA. They are called as lenticulostriate branches, very small branches. If they get occluded, and if that is causing stroke, we call it as small arterial occlusion stroke. We can also call them as lacunar strokes. So I will be doing a small separate session later for the lacunar stroke. Lacunar strokes. Okay. Then third category is cardioembolic stroke. Cardioembolic stroke. Now, what is the meaning of cardioembolic stroke? You have a pathology related to heart, which results in your increased risk of developing a thrombus, and the thrombus formed somewhere in the heart or other part of the circulation gets embolized to reach your cranial circulation, means either internal carotid artery, middle cerebral, or anterior cerebral artery. Okay. Now, can anybody tell me what is the most important cause for cardioembolic stroke? In many studies and in many countries, the cardioembolic stroke is more common than the atherosclerotic, large artery atherosclerotic stroke. In India, it is the large artery atherosclerotic strokes are much more common. But in many countries where obesity is not a big concern, in such places, it is the cardioembolic strokes which are more common. Right, atrial fibrillation. Now, can anybody explain how atrial fibrillation causes embolism? So, as we all know, atrial fibrillation refers to inability of the left atrium to contract adequately. So, this is only shaking, right? When left atrium. So, let me say that this is our left atrium. This is left ventricle. So, when left atrium fails to contract completely and just shakes, right? There is some dependent part in the left atrium, especially the posterior lower part of the left atrium. There will be stagnation of the blood. This blood is not moving because if left atrium contracts, then it pushes that blood into the left ventricle. But unfortunately, it is not contracting, merely shaking. And when blood stagnates, it has a tendency to coagulate. Why does it have a tendency to coagulate? We will get back to something that you have already studied in physiology called as Virchow's triad. What Virchow's triad says, there are three components which increase the risk of formation of a blood clot. What are those? First one, the inherent nature of the blood to coagulate, or what you call as hypercoagulability. Hypercoagulability of the blood. Like if you have antithrombin deficiency, protein C, protein S deficiency, your blood has tendency to clot easily. That is one. Okay. The second one, okay, what are the other? Right. That is the stasis. Okay. Now, how like stasis is the second component, right? What is the third component for the development of clot? The Virchow's triad, hypercoagulability. So many patients, especially stroke in young individuals, can be often because of hypercoagulable states like protein C deficiency, protein S deficiency, antithrombin 3 deficiencies, those. Okay. Then you might have seen a lot of patients after an air travel developing deep vein thrombosis. That is because of stasis, right? So when stasis happens, right, I'll come to the endothelial injury. So when stasis happens, clot, because there is stasis of this blood, a clot forms. Okay, a clot formed here in the left atrium. What is its natural destination? Where can it go? By default, anything that forms in the left atrium, its natural destination is to come to left ventricle. And if it comes to left ventricle, from there, where can it go? Left ventricle ejects its blood into aorta. So this clot will go into from left atrium. This will just go into the left ventricle. From the left ventricle, it will get ejected into aorta. Now, if that gets ejected into aorta, now you know that aorta has this force, right? An ascending, then descending aorta, and it gives us some major branches like the subclavian artery and the carotid artery. Now, what do you think? Which blood vessel is likely to get clogged by this clot? Anatomically, it is the carotid which is well aligned with the axis of the direction of flow of blood. So this clot eventually gets into the carotid, then will go into the internal carotid artery. If it is large enough, block the internal carotid artery. If it is the clot is not large enough, then it will travel further, most likely go to middle cerebral artery. That is why majority of the cardioembolic strokes cause middle cerebral artery occlusion, presenting as hemiplegia with Broca's aphasia or Wernicke's aphasia. Right. So atrial fibrillation is providing stasis, and because of that, clot forms and we develop cardioembolic stroke. So the most common risk factor for cardioembolic stroke is atrial fibrillation. Okay. Now, apart from these three types of strokes we studied, I'll come to which was tried again. We studied that large vessel atherosclerosis, which is part and parcel of aging, along with that risk factors like hypertension, dyslipidemia, obesity, increase the rate of development of atherosclerosis. The same atherosclerotic process can also cause occlusion of the small vessels, resulting in lacunar strokes. Cardiac dysfunction can result in cardioembolic stroke. Okay. Then we have a subtype called as cryptogenic stroke. Basically, the term cryptogenic is used to refer to doctor-induced or when we do not have any idea about what could be the cause. Like you can say idiopathic. Either it is iatrogenic or idiopathic. Collectively, we can call it as cryptogenic when you don't find or it doesn't fit into any of the other descriptions. Okay, so when you have an embolic stroke, but you don't know the source, like if it is not coming from heart, there's no atrial fibrillation or other arrhythmias, Such cases we can put it under cryptogenic stroke. And then we have another category, which is stroke due to uncommonly determined etiologies. Like there are a lot of disorders which cause vasculitis, and vasculitis can also provide the endothelial injury, cause a clot, and result in development of stroke. So this is the classification. They can ask you in the MCQ, what is the classification used for dividing the ischemic stroke? It is the TOAST classification. They may not ask you the full form, but they will ask you what are the common subcategories. Okay, clear? Now, having understood this broad classification, now let me take you to the next important point, that is the risk factors for ischemic stroke. We understood what is stroke, what is TIA, how do we classify stroke into ischemic and hemorrhagic, and then how do we subclassify them into the different categories based on the TOAST classification. Now we are into the risk factors for ischemic stroke. Okay, the first MCQ they will ask you is, what is the most common risk factor for ischemic stroke? Most common risk factor for ischemic stroke. And what should be your answer? This is like an MCQ that we have been asking from my times when I was studying MBBS. What is the most common risk factor for ischemic stroke? The most common risk factor for ischemic stroke is hypertension and then diabetes mellitus. Okay. Now, how hypertension becomes a risk factor for ischemic stroke? I understand the hypertension as a risk factor for hemorrhagic stroke, right? BP is too much, your blood vessel literally ruptures, bleeds into the parenchyma. In whatever area it has bled, that has lost the function. I understand. But how hypertension becomes a risk factor for ischemic stroke? Hypoxia, no. Okay. We'll get back to some basic. What is the blood pressure? What do you mean by blood pressure? Hypertension means your blood pressure elevated beyond certain threshold. What is that threshold? All that we will study later again. But beyond normal threshold, when your blood pressure is increased, we will call it as hypertension. So then what is blood pressure? How do you define it? Blood pressure is defined as the pressure exerted by the column of blood on the walls of the blood vessels. So basically, if this is my blood vessel, okay, so let us say that this is the blood vessel. So blood is flowing through it. So when blood is flowing through it, it is applying this column of blood that is moving through this blood vessel is applying the lateral pressure on the walls of the blood vessels. That is the blood pressure. So when it increases, when the blood pressure increases, when we have hypertension, what happens to the pressure exerted on the walls of the blood vessel? That is more than normal. Okay. So this extra pressure is likely to injure which layers of the blood vessel? You know, right? There is an endothelium and then the adventitia and other layers of the blood vessel. Which layer will be most injured? Obviously, the most innermost layer is endothelium. So hypertension can cause endothelial injury. It can cause endothelial injury. So when endothelial injury happens, Virchow has already told us that there is a component for Virchow's triad, which is endothelial injury. So we are again providing one of the required factors for the development of clot. So hypertension can lead to endothelial injury, which increases your chances of developing a clot. And that is how a stroke can happen in patients with hypertension. There is another possible reason. What is the other possible reason? When blood pressure increases, right? You should tell me now what happens to the work done by your left ventricle. So let me say that these are all branches of aorta, different branches of aorta, and pressure in them is increased. Now left ventricle has to eject the blood into the aorta and its branches. Its work increases or decreases? See, again I'm taking you back to some basic physics. You have heard of something called as Boyle's law. What Boyle's law says? Pressure is inversely proportionate to volume. So when you say that a particular person is hypertensive, it mostly means what? His blood vessels are in a constricted state. They have gone through vasoconstriction because upregulation of renin, angiotensin, aldosterone system or RAS axis. Blood vessels are constricted. So the volume of the blood vessels is decreased. So when volume decreases, what happens? Pressure increases. That is how we have ended up developing hypertension. And that is why we give vasodilators to treat hypertension. So when all these blood vessels are constricted, right, don't you think your left ventricle needs to do a lot more effort to push the blood into these constricted blood vessels, right? So left ventricular workload starts increasing. And whenever a muscle, the ventricle is basically a muscle, whenever a muscle does more work, it will develop hypertrophy. So then what will happen? Your left ventricle will start developing hypertrophy. Its mass or its thickness of the muscle mass starts increasing, right? It starts increasing. You might have heard of two types of left ventricular hypertrophy. One is called as eccentric hypertrophy, the other one is called as concentric. What is the difference? When I say eccentric hypertrophy, whatever muscle mass that is added, it is added outside of the existing muscle mass. So the size of the cavity remains uncompromised. And when we say concentric left ventricular hypertrophy, more and more muscle mass is added inwards inside. Like imagine a bottle. This is my left ventricle. Now I have to create hypertrophy, means I have to increase the thickness of this bottle. Either I can go on adding more plastic outside and thickness increases, that is eccentric hypertrophy. But if I go on adding more plastic inwards and the thickness grows inside, outside the bottle looks the same size. That is concentric hypertrophy, right? Whenever ventricle contracts to overcome the pressure challenge, the pressure that it is facing, we call it as afterload in physiology. So whenever ventricle is challenged by the afterload, it develops concentric hypertrophy. So in cases of hypertension, hypertension is nothing but increase afterload. So it develops concentric hypertrophy. And when it develops concentric hypertrophy, what happened to the volume of the ventricle? So if I go on adding more plastic inside of this bottle to make it more thick, what will happen to its cavity size? Decreases, right? So here the ventricle cavity size is decreased. When ventricle cavity size decreases, it will lead to enlargement of the left atrium. Why will it lead to enlargement of the left atrium? Because in your physiology, you studied that transfer of blood from left atrium to left ventricle happens in two phases of diastole. The one is called as passive filling and the other one is called as active filling. So first what happens? The blood moves from left atrium to left ventricle because left ventricle pressure would be low, left atrial pressure will be high. So from high to low, the blood moves. That's the basic physics. This is what we call as passive filling. बट मुझे अगर ये करना है तो मुझे क्या चाहिए? लेफ्ट वेंट्रिकल का प्रेशर लो होना चाहिए, एट्रिया का हाई. एट्रिया का हाई कैसे कर सकता हूं? अगर एट्रिया में बहुत से खून भर दिया तो एट्रिया का प्रेशर हाई हो गया. लेफ्ट वेंट्रिकल का प्रेशर मैं कैसे लो कर सकता हूं? लेट्स गो बैक टू बॉयल्स लॉ. व्हाट बॉयल्स लॉ सेज? प्रेशर इज इनवर्सली प्रोपोर्शनेट टू वॉल्यूम. तो अगर मुझे प्रेशर कम करना है तो वॉल्यूम बढ़ाना है, तो लेफ्ट वेंट्रिकल हैज टू रिलैक्स. तो जब लेफ्ट वेंट्रिकल रिलैक्स करके अपना कैविटी बड़ा बना देगा तो उसका प्रेशर घट जाएगा, एट्रिया का प्रेशर ज्यादा है, सो पैसिवली ब्लड विल मूव फ्रॉम एट्रिया टू वेंट्रिकल. अब जो एट्रिया से वेंट्रिकल टोटल ब्लड ट्रांसफर होता है उसमें से 70 to 80% ट्रांसफर हैपेंस थ्रू दिस पैसिव फिलिंग. Only 20% happens through active filling where atria contracts and pushes the blood to the ventricle. अब जब वेंट्रिकल की कैविटी साइज छोटा हो गया तो उसका प्रेशर क्या हुआ? वॉल्यूम डिक्रीज, सो प्रेशर इंक्रीज. सो लेफ्ट वेंट्रिकल प्रेशर is now on the higher side. So because of that, the pressure difference between atria and ventricle is less. So ये जो passive filling है वो ठीक से नहीं हो पाएगा. तो जब ट्रांसफर ठीक से नहीं हो पाएगा तो एट्रिया के अंदर प्रेशर बढ़ने लगता है. Pressure inside the atria starts increasing because it wants to put the blood to the ventricle, but ventricle is not ready to receive because उसका cavity छोटा हुआ है, उसके अंदर pressure ज़्यादा है, so it cannot transfer easily. So atria starts doing lot of work. So pressure inside the atria starts increasing. अब एट्रिया का प्रेशर हम कैसे घटा सकते हैं? सेम बैक टू बॉयल्स लॉ. आई कैन रिड्यूस द प्रेशर इनसाइड द एट्रिया बाय डायलेटिंग द लेफ्ट वेंट्रिकल. मतलब जब वॉल्यूम एट्रिया का बढ़ा होगा तो प्रेशर घटेगा. सो एज अ कॉम्पेंसेटरी मैकेनिज्म व्हेन वी डेवलप दिस कॉन्सेंट्रिक लेफ्ट वेंट्रिकुलर हाइपोट्रोफी, इवेंचुअली वी एंड अप गेटिंग लेफ्ट एट्रियल एनलार्जमेंट. And we clearly know that when left atrium gets enlarged, it is a strong risk factor for development of atrial fibrillation. So whenever left atrium increases, atrial fibrillation का risk बढ़ता है, and when you have an atrial fibrillation, you are providing stasis required for the blood coagulation. Clot बनेगा, it will come to ventricle, ventricle से aorta, aorta से carotid, carotid से middle cerebral artery, and we end up developing stroke. So there are two mechanisms hypertension can cause or lead to stroke. One, it can cause endothelial injury. Second, it increases the risk of developing atrial fibrillation with all the mechanisms that we discussed. Both will contribute to stroke. And that's why hypertension is the most common risk factor. Then the second MCQ they will ask you about the risk factor is what is the strongest risk factor for development of stroke. Hypertension is common. It's the most common risk factor, right? बाहर जाओ ओपीडी में जाओ almost every second or third patient 40 plus is having hypertension. But is there any risk factor which is even stronger than the hypertension? So in Harrison we find a table. In this table, Harrison summarizes the relative risk that a particular risk factor brings. Like, okay, there's a common individual, normal individual with no risk factors, and a person with, let me say, hypertension. So in comparison to a person with no hypertension, presence of hypertension, कितना times risk बढ़ाता है? 2 times, 3 times, 4 times, कितना x risk बढ़ाता है? This table summarizes that. So now just look at the table and tell me what is the strongest risk factor. What is the strongest risk factor when you look at the table? Hypertension relative risk increases by 2 to 5 times, 2 to 5x, right? Atrial fibrillation increases it by 1.8 to 2.9x. But diabetes, look at it, 1.8 to 6x, 1.8 to 6x. So an uncontrolled diabetes is a terrible risk factor for stroke. And that is why a good stroke, a good diabetes control is very, very important. Okay. So the relative risk can go as high as 6, and that's why it becomes the strongest risk factor. Apart from that, we know that smoking increases the risk. How smoking increases? Smoking accelerates atherogenesis because smoking leads to dyslipidemia. Smoking leads to endothelial injury. Cocktail sufficient है atherosclerosis तेज करने में, and endothelial injury is sufficient to create a clot. Okay. Then dyslipidemia causes accelerated atherosclerosis. Then carotid artery stenosis also increases the risk of developing stroke. मतलब age के साथ carotid artery shrink हुआ है, तो obviously that also reduces the blood supply and increases the risk of stroke. So if they ask you a question, what is the strongest risk factor? The strongest risk factor is going to be diabetes mellitus. Okay. Now they will ask you one more question. इन risk factors को अगर मैंने treat किया, तो can I Nilanjana, right? Obesity, hyperhomocystinemia, the list goes long. Okay. One more question they will ask you. If I treat all these risk factors for hypertension to appropriate targets, right? कौन सा risk factor treat करने से risk reduction maximum होगा? Means I have a hypertensive, I have treated him and his BP is controlled. So risk to reduce होगा. I have a diabetic, I have treated him and his risk is now reduced. So treating which of these risk factors gives you the maximum risk reduction? That's the MCQ that they will ask. So here is the table. You can see the relative risk reduction with treatment. So when I treat hypertension, I can reduce the risk by 38%. Okay. If I treat atrial fibrillation with warfarin, I reduce the risk by 68%. And if I treat it with aspirin, by 21%. Okay. And if I treat, like if I ask the patient to abstain from smoking, if he quits, there is 50% reduction in 1 year, and he is back to baseline risk at 5 years after stopping the smoking. And then if I treat someone's dyslipidemia with statins and fibrates, I can achieve up to 30% risk reduction. Carotid stenosis, if treated, it will give me the risk reduction of 53%, 65%, depending on whether the stenosis is critical or non-critical. So from the numbers, it becomes a bit clear that treating the atrial fibrillation gives you the maximum risk reduction immediately. And in the long term, it is the cessation of smoking that gives you the maximum risk reduction. So immediate best risk reduction is by treating atrial fibrillation with warfarin. That is why any patient with atrial fibrillation, we do think about initiation of anticoagulants depending on a score called as CHA2, DS2, VASC. Okay, so these are also important MCQ points. Okay. Now, having understood the risk factor, one more question they will ask you is among these, see, for stroke, is gender a risk factor? Let me also address this. Is gender a risk factor? And if that is a risk factor, which gender is at risk? Is age a risk factor? And if that is the case, which age is at risk? Okay, and what other risk factors we have? Yes, family history also is a risk factor. Gender wise, yes, it is males who are at higher risk than females, and increasing age is a risk factor because with increasing atherosclerosis increases. So one of the template of MCQs that I had been asking earlier is which of these is a modifiable risk factor and which of these is a non-modifiable risk factor. Okay. So now you tell me among all the listed ones which are modifiable risk factors and which are non-modifiable risk factors. Hypertension, a modifiable risk factor or non-modifiable? Yes, Nilanjana, absolutely right. After 65, the risk exponentially increases. So Tapa Samantha, males are not blessed by God. Basically, the hormonal milieu as well as a male lifestyle becomes the reason. So essentially speaking, estrogen has certain protective effects against vascular injury and atherosclerosis. And that is why typically the risk is more in males for not only the stroke but also ischemic heart disease, peripheral vascular disease. Plus, smoking is more prevalent in males, hypertension is more prevalent in males, so that also adds to it. But you might notice that some studies clearly show that after menopause, the risk of MI and stroke almost starts approaching that of males in females. So estrogen does play an important role. Okay. So hypertension, should I consider it as modifiable or not? Yes, metabolic syndrome, we can count it as reversible risk factor or a modifiable risk factor. Hypertension, yes, you can treat and thus you can control. And by controlling, you're reducing the risk. So hypertension is a modifiable risk factor. Atrial fibrillation, treatable, anticoagulants दे सकते हैं तो risk reduction हो सकता है. It's a modifiable risk factor. Diabetes, it's a modifiable risk factor. You can at least control the diabetes if not cure, right? Smoking रोकी जा सकती है. You can stop smoking. Hyperlipidemia can be treated. Carotid stenosis can also be treated with stents or endarterectomy, right? Okay. Genetics is non-modifiable. Family history is non-modifiable, right? Age is non-modifiable. आप कम बता सकते हो, right? You can say that you may be 50, you can say I'm 40, but still it is not a modifiable risk factor. हाँ, जेंडर मॉडिफाई हो सकता है सर्जिकली एंड हार्मोनल इंटरवेंशन की वजह से, बट रिस्क मॉडिफाई नहीं होता है. तो जेंडर इज ऑल्सो अ नॉन मॉडिफाइबल risk factor. Okay. Now we have understood the basics of stroke. We will start with how a patient with stroke presents. Okay. Now, whenever we talk about any presentation, right, the definition says focal ischemia or bleed resulting in some focal neurological deficit. Means some part of the brain is losing function and जो symptoms होंगे उसके ऊपर depend करेंगे, right? So if my frontal lobe is not getting blood supply, then I will have loss of functions of the frontal lobe and symptoms will be of that. If my temporal lobe is not getting blood supply, I will have the symptoms related to temporal lobe dysfunction. But we should be aware of the common types of presentation, right? So what is the most common presentation of a patient with ischemic stroke? The most common site of occlusion, the most common site of occlusion is middle cerebral artery followed by internal carotid artery. So if middle cerebral artery is the most common artery to be occluded, what is the likely presenting complaint? Yes, more than 85% of the patients present with hemiplegia, present with hemiplegia with or without aphasia. So that is why whenever we see a patient with hemiplegia, we first think of stroke, right? But that does not mean that everyone who presented with hemiplegia is having stroke. Okay, clear? So the most common presentation of stroke, if they ask, it is hemiplegia that is seen in more than 85% of the patients. Remaining patients may have other presentations. Okay, but 85% of the cases they present with hemiplegia. So now imagine that you got a patient with hemiplegia. It's acute onset, sudden onset. You are thinking of stroke, right? How do you take the case forward from here? आपको लग रहा है कि शायद ये stroke की वजह से. So what all you need to know? First thing you need to know is how will I confirm that this is stroke? And then second thing you need to know is that if I know that this is stroke, मुझे आगे कैसे manage करना है? Right? What are the management steps? Thrombolysis करना है, endarterectomy या thrombectomy करना है या conservatively सिर्फ antiplatelets दे के treat करना है, anticoagulants देना है या नहीं देना है, time frame क्या है? All that we need to understand. Right? But before that, let me tell you that when we see a patient with stroke, we should have a clear goals in mind. क्यों treat करना चाहता? right? So I had already drawn this image. When we have a patient with stroke, basically two things are happening. A blood vessel is blocked. Because of that, some area of the brain is not getting blood supply. And because of that, some part of the brain is already dead. Some part of the brain is on the way to death. Okay. Now, if I remove this clot by whatever treatment modality, will I be able to revive this dead part of the brain? Will I be able to revive the dead part of the brain? The answer is no. And there are theories that neurons have some degree of plasticity, some degree of regeneration may happen, but it is negligible. So the impacted area is gone forever. But the surrounding area that we call as ischemic penumbra, this is not dead. We can save it. So when I see a patient with stroke, whatever functional deficits we are seeing, whatever function he has lost, it is because of this whole area. Because this whole area means impacted area plus the ischemic penumbra. Both of them are not functioning. So when I see him having hemiplegia, it is because of impacted area plus ischemic penumbra. But if I treat and if I clear the clot and re-establish the blood supply, this area will bounce back. Only the impacted area is lost. So this area function will reappear. They will come back. You would have lost the functions of this ischemic penumbra area, but once I re-establish the blood flow, they will come back. So what is the goal of treatment? The goal of treatment is not for the normalization of this impacted area, but the goal of treatment is to revive the ischemic penumbra so that the functions lost by the ischemic penumbra are recovered, right? So if I have to write the important goals of the stroke management, the first one is to salvage ischemic penumbra. अब ऐसा क्यों करना चाहता हूं? Because if I leave that area also to die, then जो पेशेंट डेफिसिट्स लेके आएगा उसी के साथ घर वापस जाए. He will go home provided he survives with the same degree of deficits. But if I make this area functional again, so when he goes home, he will not go with the same degree of deficits, right? आते वक्त dense hemiplegia लेके आएगा, जाते वक्त mild hemiplegia के साथ जा सकता है. So at least this function I can recover. So can I say that the main goal of treatment is to save the ischemic penumbra so that we can limit the deficits or disability. तो मेन गोल वही है स्ट्रोक ट्रीटमेंट का, टू लिमिट डिसेबिलिटी. तो जो इंपैक्टेड एरिया है तो वो गए, हम कुछ नहीं कर सकते हैं उसके लिए, लेकिन सराउंडिंग एरिया को बचा के हम डिसेबिलिटी को लिमिट कर सकते हैं. और तीसरा गोल क्या है? टू रिड्यूस मॉर्टैलिटी, जो डेथ ड्यू टू स्ट्रोक होता है उसको रिड्यूस करना है. एंड चौथा गोल क्या है? See, if a patient has presented with stroke, that means उसके पास रिस्क फैक्टर्स तो है, हाइपरटेंसिव होगा, डायबिटिक होगा, डिस्लिपिडेमिक होगा, स्मोकिंग करता होगा, रिस्क फैक्टर्स तो है. इस बार तो मैंने कैसे कुछ करके डिसेबिलिटी को लिमिट करके घर भेजा है, बट ही विल कम बैक अगेन विद अनदर एपिसोड ऑफ स्ट्रोक. तो उनको भी हमें प्रिवेंट करना है, राइट? सो वी शुड ऑल्सो थिंक ऑफ टू प्रिवेंट फर्दर एपिसोड्स ऑफ stroke, further stroke episodes. Now you should tell me, how can I prevent further episodes of stroke, right? And how can I save the ischemic penumbra? Ischemic penumbra सेव करना आसान है, right? Whatever blood vessel that was blocked, इस blood vessel को जितना जल्दी हो सके उतना जल्दी उस clot को dissolve करो, clear it so that you can re-establish the blood flow and at least we can save the ischemic penumbra, right? Simple. How can we do that? I will come to that point. But before that, you should tell me now, how can I prevent further stroke episodes? कैसे प्रिवेंट कर सकता हूँ? सिंपल है, रिस्क फैक्टर मिटिगेशन, राइट? मैनेज द रिस्क फैक्टर. हाइपरटेंशन है, बीपी को कंट्रोल करो, टारगेट के रेंज में लेके आओ. डायबिटिक है, ब्लड शुगर को कंट्रोल करो. डिस्लिपिडेमिक है, कोलेस्ट्रॉल को कंट्रोल करो, राइट? मिटिगेट द रिस्क फैक्टर्स. So now can I call this as some kind of prevention? And if I'm calling it as prevention, should I call it as primary prevention, secondary prevention, or tertiary prevention, or primordial prevention? We are trying to modulate the risk factors, but कब ऑलरेडी एक स्ट्रोक हो चुका है, अगले स्ट्रोक को प्रिवेंट करने के लिए हम रिस्क फैक्टर्स को मॉड्यूलेट कर रहे हैं और कुछ मेडिकेशंस भी दे रहे हैं जैसे कि एंटीप्लेटलेट्स, स्टैटिन्स वगैरह. Yes, we will be giving clopidogrel, dual antiplatelets initially, बाद में सिर्फ एक. So all this, should I call it as primary prevention, secondary prevention, primordial prevention, or tertiary prevention? PSM में you might have already studied, right? So let us take an example. I have hypertension. Okay. Hypertension, we know that it leads to stroke. So if I start treating hypertension so that I don't go to stroke, we will call it as प्राइमरी प्रिवेंशन. मतलब हाइपरटेंशन है, स्ट्रोक ना हो इसलिए हम हाइपरटेंशन को कंट्रोल कर रहे हैं, दैट इज प्राइमरी प्रिवेंशन. ओके. देन एक बार स्ट्रोक हुआ है, राइट, उसके बाद में हम वट एवर मेजर्स वी आर टेकिंग कि अगले बार दूसरा स्ट्रोक ना हो, फॉर दैट वी आर गिविंग द रिस्क फैक्टर मिटिगेशन भी कर रहे हैं, हाइपरटेंशन को ट्रीट कर रहे हैं, उसके साथ में एस्पिरिन, क्लोपिडोग्रेल ये सब दे रहे हैं. देन वी विल कॉल इट एज सेकेंडरी प्रिवेंशन. ओके. अब जो स्ट्रोक हुआ है, that is caused him disabled, hemiplegic है, ठीक से काम नहीं कर पाएगा, right, he has become bedridden, wheelchair bound, so we are trying to make his life easier by giving him a wheelchair, support devices, basically rehabilitation कर रहे हैं. So that rehabilitation will be considered as tertiary prevention. Rehabilitation will be considered as tertiary prevention. But if the individual takes care of his salt intake, obesity ना हो ये कोशिश करेगा, he takes care of his good health so that he doesn't become hypertensive at all, मतलब risk factor emerge होने से रोक रहा है, then we will call it as primordial. Primordial means we are preventing the risk factor from emerging. Hypertension होने से पहले ही he is taking care of his lifestyle, then it is primordial prevention. So this we will count it as secondary prevention because already an episode of stroke has happened. We are trying to mitigate further stroke development. We will call it as secondary prevention. Okay. Now I will make one important statement that I want you to remember throughout your medical career. जब पेशेंट आपके साथ आपके पास स्ट्रोक लेके आएगा बिकॉज देयर वाज अ क्लॉट इन द ब्लड वेसल, राइट, देयर वाज अ क्लॉट इन द ब्लड वेसल. अब इन्फार्क्ट का साइज क्या होगा और इस्केमिक पेनम्ब्रा का साइज क्या होगा, ये किस फैक्टर पे डिपेंड करने वाला है, राइट? हाउ बिग विल बी द इन्फार्क्ट एंड हाउ बिग विल बी द इस्केमिक पेनम्ब्रा. ये पूरा एरिया एक ब्लड वेसल से सप्लाइड है और मैंने इसको ब्लॉक किया है. आने के टाइम पे इन्फार्क्ट इतना होगा और इतना बड़ा इस्केमिक पेनम्ब्रा होगा, या इतना बड़ा इन्फार्क्ट होगा और छोटा सा इस्केमिक पेनम्ब्रा होगा. ये कौन से फैक्टर पे डिपेंड करने वाला है? टाइम, राइट? As early as patient presents, right, we will have smaller infarct area and recover करने वाला एरिया ज्यादा रहेगा. जितना लेट पहुंचेगा इन्फार्क्ट एरिया उतना बड़ा होगा, रिकवर करने का एरिया कम होगा. सो कैन आई से दैट टाइम इज ब्रेन. जितना टाइम हम गवाएंगे उतना ब्रेन टिश्यू हम गवाएंगे, राइट? टाइम इज द ब्रेन. द मोर टाइम वी लूज, मोर ब्रेन टिश्यू वी लूज, पेशेंट विल बिकम मोर डिसेबल्ड, राइट? पेशेंट को डिसेबल्ड, बेड रिडन होने की चांसेस ज्यादा है वो जितना लेट पहुंचेगा. सो दैट इज व्हाई वी हैव टू रिकॉग्नाइज स्ट्रोक वेरी अर्ली. एज अर्ली यू रिकॉग्नाइज, चांसेस है कि डिसेबिलिटी को आप बहुत कम रखेंगे या पूरा नॉर्मल इंडिविजुअल करके आप वापस भेज सकते हो. तो क्वेश्चन क्या है, हम स्ट्रोक को कैसे आइडेंटिफाई अर्ली कर सकते हैं? As a doctor, obviously we should have enhanced skills to recognize the stroke early. History taking से लेके examination we should be good. But ज्यादातर प्रॉब्लम क्या होता है, पेशेंट के फैमिली मेंबर्स स्ट्रोक को लेट रिकॉग्नाइज करते हैं. दे ब्रिंग द पेशेंट आवर्स और समटाइम्स डेज आफ्टर द स्ट्रोक कॉन्सेप्ट. तब तो आप कुछ भी नहीं कर सकते हो, पूरा एरिया ही इम्पैक्ट हो चुका होगा. थ्रोम्बोलाइसिस, मैकेनिकल थ्रोम्बेक्टमी का कोई स्कोप ही नहीं बचता है. तो पहला स्टेप क्या है, अर्ली रिकॉग्निशन ऑफ स्ट्रोक में वी हैव टू एजुकेट द पेशेंट अटेंडर्स टू रिकॉग्नाइज द स्ट्रोक अर्ली. अगर वो अर्ली रिकॉग्नाइज करेंगे तो हॉस्पिटल अर्ली आएंगे तो हम आगे लेके जा सकते हैं, राइट? सो फॉर दैट देयर इज एन एल्गोरिथम कॉल्ड एज आई थिंक मोस्ट ऑफ यू मेंशन्ड, यस, दैट इज बी फास्ट एल्गोरिथम. बी फास्ट algorithm. So in terms of MCQs, they will ask you what are the components of this B fast algorithm. मैं अपनी प्रैक्टिस में क्या करता हूँ, आई नो दैट ऑल दीज आर रिस्क फैक्टर्स फॉर स्ट्रोक, राइट? हाइपरटेंशन, डायबिटीज, एट्रियल फिब्रिलेशन, डिस्लिपिडीमिया, स्मोकिंग, जेंडर, एज, दे आर ऑल नॉन रिस्क फैक्टर. तो जो भी मेरे पेशेंट्स होंगे जिनमें ये रिस्क फैक्टर्स प्रेजेंट हैं, आई टेक सम टाइम, टॉक टू द पेशेंट बट एज वेल एज द अटेंडर्स about the B fast, educate them about the B fast. ताकि okay they know that okay my this family member मेरा father या mother my elderly brother is at risk of stroke, and if I see any of these parameters in him, that may be stroke and I should take him to the hospital immediately, right? So let us understand what that B fast stands for. Okay, so B fast as the B fast, it's an acronym for the components. So what we are looking for, B here stands for balance. Okay, so if there is any noticeable issues with balance, if patient has imbalance in walking or gait, or if he feels dizzy, right? So any degree of imbalance, that stands for B. E here stands for eyes. So any issues with eye vision as well as eye movement. If patient is not able to move the eyeballs or if he is not able to see properly, then that is E. F here refers to face. So if patient notices any asymmetry of the face, you know that it indicates the facial nerve palsy or the stroke. And then if patient notices or patient attenders notice that there is any weakness of arms, one or both the arms. A here refers to arm. S refers to speech. Any abnormality of the speech. Struggling to speak, not able to produce, not able to understand speech, right? Not able to understand, probably Wernicke, not able to produce speech, probably Broca's. So any issues with speech. If among these, any one is also present in a patient, right? He has lost balance or he's feeling dizzy, he has issues, sudden onset vision issues or eyeball movement issues, if his face has become asymmetric, or if he has developed arm weakness, or if he has developed speech issues, if any one of them are present, then without wasting time, T here refers to time. Without wasting time, the patient should be brought to the medical care facility. In USA, they have this 911. In India, we have 108. So patient attenders are instructed to call 108, rush an ambulance, and quickly get him to the hospital without wasting an iota of time. Time is very important, right? Time is brain. So educate the patient attenders about the B fast algorithm. Okay. Now, once the patient attenders understand and they bring the patient early to the hospital. Now, there's another challenge. As a doctor, you should also be able to recognize that whatever I'm seeing is a case of stroke. Because यहाँ वहाँ हमने time waste कर दिया, तो again every minute of brain, every minute of time we lose, we are losing some amount of neurons in the brain. So as a doctor also, I should be able to recognize it. Usually क्या होता है, when in an early phase of stroke, when patient is having very subtle weakness, he will start saying, because उनको पता है मेरा right hand का strength क्या है, left hand का strength क्या है. So if he notices that okay my right hand is slightly weaker, he will recognize it. So he will tell the attenders will bring him to the hospital. उनको भी fast पता है. But when you examine, आपको लगता है दोनों साइड का power 5 out of 5 ही है. So in that case, you will discard this saying that okay, this is not a case of stroke. शायद थोड़ा सा anxiety होगा, stress होगा. You will send the patient home, and then they will come back again after half an hour, 45 minutes with a full-fledged deep or the intense stroke, intense hemiplegia, right? Power पूरा 5 से 0 बन चुका है. But this time, beware that not only the patient will come back with the full-blown hemiplegia, but people will come, they will create ruckus in the hospital. And they're right also. मतलब, हाँ, violence is not supported, but that presented to you well in time when the stroke was evolving, not in a full-blown state. You should have recognized it. आपने recognize नहीं किया, घर भेजा thinking that he is tense and anxious. Now he has lost the one side of the body movements completely, and now शायद पूरा impact पे होगा, तो probably will not be able to make him less disabled. तो इससे हम कैसे बच सकते हैं? How can I recognize stroke जब power loss very subtle है, मुझे examination में दोनों साइड 5 out of 5 ही लग रहा है, then how can I recognize it? So even when subtle weakness happens, it is recognizable, right? There is a sign called as Barry's sign, or if you want to pronounce it as, you can also call it as Barry's sign. Barry's sign or Barry's sign, which is also called as pronator drift sign. During bedside discussion, we often ask students to demonstrate this sign, how to demonstrate pronator drift sign. So basically what happens, we have to ask the patient, whenever आप suspect कर रहे हो कि, or at least patient is complaining that one side is slightly weaker or he is feeling that it is not as strong as the other side, ask them to stretch their hands out and hold in supine position like this. अगर किसी एक साइड वीक है, पावर में तो दोनों 5 out of 5 ही होंगे, बट थोड़ा सा वीक है किसी एक साइड, that side from supine it will slowly start pronating and drift away and fall down. Patient will not be able to hold it for more than 30 seconds. If he is able to hold it for more than 30 seconds, fair and good. That means both the sides power is fine. He probably does not have stroke. But if एक साइड slowly pronate होने लगता है and then drifts down, we call it as pronation and drifting. So we call it as pronated drift sign, and it is named after the neuroscientist who first proposed this, called Barry. So we call it as Barry sign. तो अगर ये हम डेमोन्स्ट्रेट कर सकते हैं Barry sign है present, that means there is damage to pyramidal tract. Pyramidal tract कहाँ से start होता है? Motor cortex, subcortex, brainstem, spinal cord. कहीं पे तो डैमेज है, most likely because of stroke, right? So that is why this Barry sign is also considered as the earliest sign of pyramidal tract damage. Earliest sign of pyramidal tract damage. This is also an MCQ. And nowadays they have started giving you these GIF based questions in NEET PG. So they will make a small GIF of this, right? There may be a GIF video which is showing this, and then they will ask you what sign is being demonstrated or where is it seen. So you should be familiar that this is called as pronated drift sign. This is the earliest sign of pyramidal tract damage, most commonly elicited in subtle strokes. When you have subtle strokes, not very evident at presentation, you should do that. Like, trust me, you start doing it for any patient who says that my one side is slightly weaker than the other side in the emergency room. अगले 10 cases में कम से कम एक या दो में you will be able to recognize stroke much earlier by doing this sign. We are calling it as Barry's sign. So there are two things for early recognition of stroke: B-fast algorithm and Barry's sign or pronated drift. So now we know how to recognize the stroke early. We know what is stroke, what is TIA, what are the risk factors for stroke, the Toast classification of ischemic stroke, and early recognition of stroke is done. We will now talk about the evaluation of a patient presenting with stroke. And in the subsequent sessions, we will talk about the management. So now that I have clinically recognized that this patient has stroke, how should I proceed further? मेरा goal क्या है stroke treatment का? I have to save the ischemic penumbra, right? And then I have to keep the patient least disabled when he goes home. वो तभी possible है जब मैं ischemic penumbra को मरने से बचाता हूँ. उसे बचाने के लिए मुझे blood vessel में हुआ clot को निकालना है, right? Okay. So when I get a patient with stroke, मेरे सामने पहला क्वेश्चन क्या होगा? Ischemic stroke है या hemorrhagic stroke? Because if I have an ischemic stroke, then I have to dissolve this clot. Probably I will give medications to dissolve the clot, or I will put a wire and pull this clot out. But if I give the medications to dissolve the clot, but unfortunately this was not an ischemic stroke, but there was a bleed. So bleed क्या होगा? और increase होगा. So the treatment of ischemic stroke can literally kill the patient with hemorrhagic stroke. तो ये risk तो मैं नहीं ले सकता हूँ. So whenever we suspect a case of stroke, first step is to differentiate and clearly understand whether I have ischemic stroke or hemorrhagic stroke. तो उसके लिए मुझे क्या करना पड़ेगा? पहले when you have a suspected stroke, what is the first step? What investigation can help me to differentiate between ischemic stroke and hemorrhagic stroke? So those who understand a little bit of radiology, let me ask you a question. जो infarct होता है वो CT स्कैन में दिखने के लिए कितना टाइम लगता है? An infarct will be visible on the CT scan by how much time? So infarct becomes visible on a CT scan after 6 hours. Visible on CT after 6 hours. तो जो पेशेंट स्ट्रोक में आधे घंटे बाद या 40 मिनट बाद 2 घंटे बाद आया है, will I be able to see an infarction on the CT scan? Will I be able to see the infarction on the CT scan? The answer is no, right? So then why are you telling me that I should now be doing a CT scan? MRI can pick up an infarction within a few minutes of the onset of infarction. But all of you are absolutely right. The investigation of choice is CT scan. Q. So when you have a suspected case of stroke, you should do a CT scan. Why? Because the CT scan इज वेरी एफिशिएंट इन रिकॉग्नाइजिंग ब्लीड। मेरे पास सीटी स्कैन करने के पीछे एक क्वेश्चन है, मेरे दिमाग में एक क्वेश्चन है, मैं जानना चाहता हूं कि ब्लीड है या इश्केमिक है, हेमोरेजिक है या इश्केमिक है। तो सीटी स्कैन कैन क्लियरली रिकॉग्नाइज हेमोरेज। तो अगर सीटी स्कैन में हेमोरेज नहीं है तो बाय डिफॉल्ट इट मींस आई एम डीलिंग विद द केस ऑफ इश्केमिक स्ट्रोक। जो सवाल है मेरे दिमाग में उसके लिए सीटी स्कैन आंसर देता है। इन्फाक्ट को नहीं दिखा रहा है मुझे, बट ब्लीड नहीं है ये तो क्लियरली बता रहा है, राइट। सो दैट इज व्हाई वी डू अ सीटी स्कैन। एमआरआई क्यों नहीं कर रहे हैं? बिकॉज एमआरआई कैन टेल मी आइडेंटिफाई दैट देयर इज एन इंफाक्शन बट टेक्स अ लॉट ऑफ टाइम। मिनिमम टाइम इट टेक्स इज 45 minutes, and when it comes to stroke, time is brain. I don't want to lose the time, that's why we choose the CT. अब कॉन्ट्रास्ट देना है नहीं देना है? Again, contrast takes time and does not add anything more. That's why we don't give the contrast. So the investigation of choice will be non-contrast CT scan. This can clearly tell me whether there is bleed present or not. I'm not even looking at the presence of infarction. मेरा क्वेश्चन है कि bleed है या नहीं है. If bleed is present, then it is a hemorrhagic stroke. Then it is hemorrhagic stroke. And if there is no bleed, then it is ischemic. So all I need to see is there is no bleed. As long as there is no bleed on the CT scan, it will be counted as an ischemic stroke. Nilanjana, right. So it takes a lot of, we need to give oral contrast, IV contrast. It takes plenty of time. So it doesn't solve any purpose, doesn't add any extra information that I see. जब भी हम कोई इन्वेस्टिगेशन करते हैं तो उससे पहले ही हमको पता होना चाहिए कि ये इन्वेस्टिगेशन क्यों कर रहा हूँ, मेरा ऑब्जेक्टिव क्या है. My objective is not to visualize the whole brain. My objective is to understand whether there is bleed or not, and that doubt is clearly solved by the CT scan. That is why the investigation of choice is CT scan. अब एक क्वेश्चन है, ये जो CT scan है मुझे पेशेंट प्रेजेंट होने के कितने घंटे के अंदर करना लीगली. Pretty important point, right? Like it's not like, okay, emergency patient came, I did the pronator drift sign बहुत early, before even the power has dropped, I could recognize कि हाँ patient has got the possible stroke. लेकिन अब खुश हुआ हूँ ना कि I have recognized a Barry sign positive patient before even power goes down. I have recognized a case of stroke. अब इस खुशी में बाहर जाते हैं, चाय पीते हैं, थोड़ा सा सुट्टा मारते हैं, फिर वापस आके सीटी स्कैन करेंगे, चलेगा? नहीं. सुतापा, दैट इज व्हाट आई एम ट्राइंग टू टेल यू कि सीटी स्कैन करने के पीछे एक ऑब्जेक्टिव है. ऑब्जेक्टिव क्या है? मैं इन्फार्क्ट देखने के लिए सीटी स्कैन नहीं कर रहा हूँ. व्हाई एम आई डूइंग द सीटी स्कैन? ब्लीड है या नहीं ये देखने के लिए सीटी स्कैन कर रहा हूँ. ब्लीड नहीं है तो इश्केमिक स्ट्रोक है, ब्लीड है तो हेमोरेजिक स्ट्रोक है. तो सीटी स्कैन ये बताने में बहुत ही सेंसिटिव है, ब्लीड को रिकॉग्नाइज करने में. तो सीटी में ब्लीड नहीं दिखता है तो बाय डिफॉल्ट इट विल बी काउंटेड एज इश्केमिक स्ट्रोक. So CT scan should be done. Two important points to remember here. Should be done within 25 minutes of presentation. उससे ज़्यादा आप टाइम ले रहे हो तो you can be sued for negligence. 25 minutes of presentation and read. ऐसा नहीं है कि हाँ 25 मिनट्स के अंदर खत्म कर दिया है फिर आप सो जाते हैं, सुबह उठ के देखेंगे कि सीटी में क्या दिख रहा है. No, it should be read by an expert. Expert here is need not always be radiologist. Any doctor will be counted as expert. A physician, neurologist, emergency room physician, critical care specialist, radiologist, everything, right? Read by an expert within 45 minutes. Within 45 minutes. This is legal binding on us. हाँ, सो अगर सीटी स्कैन में रेडी ब्लीड नहीं दिखता है तो विल काउंट इट एज अ केस ऑफ इश्केमिक स्ट्रोक. सीटी स्कैन में ब्लीड दिखता है तो ब्लीड इमीडिएटली दिख जाएगा. अगर राइट नाउ इफ आई डेवलप अ ब्लीड, नेक्स्ट मिनट सीटी स्कैन में वो दिख जाएगा. ब्लीड वोंट टेक टाइम टू इवॉल्व. इन्फॉक्शन टेक्स अप टू 6 hours टू अपीयर ऑन द सीटी स्कैन. तो अगर इफ आई डेवलप सडनली हेमीप्लीजिया नाउ, if you do a CT scan, if I have developed the bleed, it will be immediately visible. If it is not because of bleed, then CT scan will turn out to be normal. अगर CT scan normal दिखता है तो इसका मतलब क्या है? I have ischemic stroke. Clear? Okay. So now we have understood why normal contrast CT scan becomes the investigation of drugs. Now in today's practice, most of the sophisticated tertiary or quaternary care centers They don't only do the CT scan, normal CT, non-contrast CT scan. Along with the CT scan, we go ahead and give the contrast, and we quickly get a CT angio done. We'll quickly get a CT angio done. Okay, so you should tell me, why are we getting the CT angio done? Why are we getting the CT angio done? So if the stroke is hemorrhagic stroke, then there is a different protocol that we will be following for the hemorrhagic stroke. Agar hypertension hai, so we need to consider lowering the blood pressure. The bleed into the brain parenchyma would have increased the intracranial pressure. So we have to take the measures to reduce the intracranial pressure. And then we have to look at the midline of the brain. Agar wo shift hua hai, so that means there is a possibility of, there is significantly elevated intracranial tension. There's a possibility of brainstem herniation and death. So in that case, we have to also do the क्रेनियोटॉमी और क्रेनिएक्टमी, एंड जो हेमाटोमा है उसको शायद एवैक्यूएट करने की भी जरूरत पड़ सकती है. हाँ, so now I will be concluding it here for today. In the subsequent session, what we are discussing is, once we have recognized ischemic stroke, we have many treatment options, right? I will tell you the options. One option is we can dissolve the clot that is there in the blood vessel, right? This is a blood vessel which was supplying a particular area. We have developed an infarct. हमें in ischemic penumbra को save करना है. So there is a clot here. I can dissolve this clot. So when I can dissolve the clot, we call it as thrombolysis. Thrombolysis. Second thing I can do is I can put a wire and pull this clot out, clear this clot. We will call it as mechanical thrombectomy. Mechanical thrombectomy. The third thing I can do, if these two are not possible, at least मैं ये काम कर सकता हूँ कि ये जो क्लॉट है ये इससे आगे प्रोपोगेट ना होते जाए, इससे बड़ा ना बनता जाए और दूसरे ब्लड वेसल से क्लॉट ना बन जाए. इसके लिए आई कैन गिव देम एंटी प्लेटलेट्स and I can give them statins so that atherosclerosis doesn't progress. So these are the basic options. Giving antiplatelets and statins, as we know, is kind of secondary prevention, and the mainstay of treatment is going to be either dissolving the clot or removing the clot with a mechanical device, what we call as mechanical thrombectomy. Okay, so I will leave you here because we will be discussing it tomorrow. What I would suggest is go through some MCQs on the management of stroke. There is a reason why I am leaving you at this point, because majority of your confusion is going to be about when do I choose thrombolysis, when do I choose mechanical thrombectomy. जितना ज़्यादा क्वेश्चन सॉल्व करोगे उतना ही कंफ्यूजिंग लग सकता है. So first you try solving the questions and I will address how to handle those kind of questions in the MCQs. How to make a choice whether thrombolysis करना है and mechanical thrombectomy करना है. One point here is that I just gave you an important clue that most of the sophisticated centers जैसे कि tertiary या quaternary centers in Bangalore, Delhi, Mumbai, metros, we, as soon as patient presented with stroke, normal contrast CT के साथ साथ quickly we get a CT angio also done, right? Think about it कि हम वो किस लिए कर रहे हैं. जो सवाल हमारे पास है कि हेमोरेजिक है या इश्केमिक है, उसको सॉल्व करने के लिए नॉन कॉन्ट्रास्ट CT काफी है, बट वी स्टिल पुश एंड गेट अ CT angio done. वो क्यों कर रहे हैं? हाउ इज इट गोइंग टू इन्फ्लुएंस माय चॉइस बिटवीन थ्रोम्बोलाइसिस एंड मैकेनिकल थ्रोम्बेक्टमी? So that was Samantha. I will bring a video of a patient undergoing mechanical thrombectomy which has shown a dramatic result. मतलब patient had hemiplegia, clot यहाँ से निकाला, वहाँ पे patient की movements improve होना शुरू हुआ. Very dramatic result. I will try to bring in, and I will also see if I can bring in some more patient videos in the next class. Okay, so for today this is it. We have understood the basics of stroke. In the next session we will be talking about the management of stroke. In terms of distribution of MCQs, 80% of the questions from stroke are on the management of stroke. So that we will address in the next session. Till then, have a good time, guys. I'll see you soon. Bye bye. Good night.